Welcome to Dr. Jeffre Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Darrell Craig Harris.
Well, welcome back.
Thank you very much. So this is Dr. Jeffre Roth, your board-certified plastic surgeon here in Las Vegas, Nevada, and we are actually live from the office today. Our usual studio is getting renovated, and so we're looking forward to getting back into there. But right now, you're stuck with us from the closet here in our office. So.
It's a fabulous office. So today we're going to cover post-op care, but first we're going to answer some questions from our previous episode, which was covering scarring and dealing with that.
So we get questions, and one of the questions again we were talking about is scars and scarring, and especially stuff on the face, stuff on the breast, stuff with the tummy tuck incisions, and so some people are concerned not at all with the scars. For example, folks that, some folks, not everybody, but some folks that have lost, 200 pounds weight loss, and they come in, they say, "Hey, doc, I just don't want to fold my skin into my pants anymore."
Yeah, they just want the tummy tuck and they don't care.
And they just, please just take this off. And that's cool. And that's fine, especially if they have rashes underneath, et cetera, et cetera. And so that's fine. So some people really, don't mind. And then some people really do. And as a plastic surgeon, especially working in aesthetics, you try to hide the scars best you can and try to put your ducks in a row the best you can so as to get the best result. And we talked about what's good for scarring, and we talked about keeping out the sun, we talked about nutrition, we talked about no smoking. A couple of the questions that we got were about silicone strips, which I think are good. Silicone in contact with the scars are good. We like the stuff that's a liquid silicone, which then gets kind of tacky. And also compression I like, and I also like massage. And so we talked about that a bit. And then we also talked about hypertrophic or keloid scars, where the scar tissue is heaped up. And one of the things that we neglected to talk about, which a couple of people call me on, which we do here in the office, is if it starts to look a little bit hypertrophic or a little bit like a keloid, meaning that it looks like a bit heaped up, like a speed bump or a little red, then oftentimes we will have people massage it, we'll have people keep out the sun, but sometimes we'll also go ahead and put a little bit of Kenalog in there, which is a steroid. Now, not steroid like make it big and strong, steroid like anti-inflammatory, and we inject that into the scar. Now, typically that really helps, takes down the speed bump, if you will, and takes down some of the redness, and sometimes takes down some of the itching as well. Now, my algorithm is a little bit different, maybe, but I think most folks that trained the kind of way I did is you see a scar, it's starting to look a little iffy, okay, fine. So sometimes you wait, sometimes you don't. Scars typically look their most red and most raised at about 4 months. So if somebody comes in with that and it's 4 months, I'm like, okay, well, let's go and wait a little bit. But then if we say, all right, well, let's go ahead and jump on this, we'll go ahead and do an injection of the Kenalog, and then typically we'll wait 4 to 6 weeks, and then we'll see them again. Maybe we'll do a second one, maybe we'll do a third one, right? So my algorithm is kind of 3 Kenalog shots, and then there's other injectables that we could use. And then you got 3 shots of those, and then after that, then in my head, we're like, maybe we have to talk about excision, maybe we have to talk about doing something a little bit different. And again, as we talked about the last show, we talked about different modalities like pressure, we talked about silicone sheeting, we even talked about radiation in some cases. But we got a few questions on that, and they asked about that thing, and so I wanted to clarify that. So I appreciate that opportunity.
Yeah, and we should say we like questions. It's actually where we get a lot of our topics. So feel free to send those in. You can either contact Dr. Roth at the office, or you can send us emails, messages on the social media. All forms are acceptable.
Yeah, no, we actually do look at that stuff. And sometimes I'll get that message on the Instagram in the DMs. They're sliding into my DMs, whatever that means. I don't know what that means. And they'll say, hey, is this a doctor? And I'm like, well, yes, most of the time, but I also have people that help me with that as well, because, again, I when it comes to social media and things, technology, I need help. Surgery, I've been really trained well to do that, but yeah, some of the technical stuff.
And you're very busy.
Not so much. So I thankfully have a really good team that helps me out a lot with that. So,
that's me.
That's right. Yes.
So
I'd say that even if he wasn't staring right here.
So post-op care, that's a very big topic. Has a lot of different meanings to different people. Let's talk about that.
Sure. So post-op care, again, we've talked about this a couple of times. You can be the best surgeon in the world. I am not. I've been trained by some of the best, and I just try to emulate them. But especially in hand surgery, for example, is you can be the best hand surgeon in the world, and you do great surgery, and if the patient doesn't go to occupational therapy and doesn't do the little squeezy ball and doesn't do the range of motion, you're not going to get a result. So basically, pre, during, and post-op care in my world is really important and really sets the stage or lines up your ducks in a row, whatever you want to call it, to go ahead and get you the best result possible. So people ask, okay, what can I do? What can I eat? What can I, to go ahead and get the best results? And a lot of it is stuff that you shouldn't do, and we talked about that. I mean, you got to kind of lay off the meth a little bit and that, but
no smoking.
So yeah, the main thing, no smoking anything. So yeah, basically smoking is bad and evil. Nicotine we really don't like because it's a vasoconstrictor and you don't get the blood supply where you need it. And by nicotine, smoking is bad, vaping is bad, nicotine even in the patch, even in chew, it's still that vasoconstricting stuff. Now, cigarettes also, you have a lot of other stuff that gets aerosolized, et cetera, but yeah, so that's a really big one. And again, we had discussed this before, is many of my colleagues won't do and I won't do facelifts on smokers. That goes from breast lifts and tummy tucks to Ys, because all those three operations, on purpose, you're making things perky, but you're putting them on tension, and tension's the enemy of good wound healing. Yeah. So basically, you want to go ahead and get as much blood supply and as much oxygen as you can to those tissues, and nicotine does not help with that. But so people ask, okay, what can I eat? Well, you have to eat food. And what I mean by that is protein, some vegetables, some vitamin C, et cetera, to go ahead and get the collagen to line up right and get together as a scar, and some carbohydrates as well, because you're going to need some energy, because we're creating trauma. I'm a nice guy, but I take a knife to people, and I create trauma.
And your body doesn't know that you're a plastic surgeon.
Right.
Or their body, I should say.
Right. So there's certain things that happen in the inflammatory response. Since caveman, times, things will swell up. Oftentimes, especially my tummy tucks, patients, they'll get upset and they'll go, wait a minute, you took all the stuff off my tummy tuck, and I'm up 5 pounds. And the answer is, well, yes, you are. And I usually tell the husband or boyfriend to take the scale and put it in the garage for about a month, because they won't fit in the rings, they won't fit into their skinny jeans and stuff.
Right, the body has to adjust.
Right, completely normal. So nutrition, again, you don't have to do the Linus Pauling craziness with the vitamin C, but basically you have to eat food, and it's important because, again, we get everybody, but we get from anorexic models to whatever, and we talk about nutrition, and it was beaten into me as a general surgeon, because where I trained, that's where they started really looking at nutrition. They started about feeding people via the IV, and they started all this stuff. And so that was really one of their focal points. And we learned that those folks that have nutrition, they heal up wounds better. And again, if somebody comes in, you see somebody in the hospital with a bed sore, right, a pressure sore, and if they're a little old lady in the nursing home that's eating saltines for 6 months, you can be the best plastic surgeon in the world,
overcome that,
and it's not going to work. So it's just, you're sewing to wet toilet paper, and you put it together, and even if it's gorgeous at the end of the case, it's not going to work. So nutrition, and I used to, the people always knew when I was rounding in the hospitals, because I would run nutritional panels, and like, oh God, Dr. Roth's here again, and to see if this patient would actually be a candidate for appropriate surgery, et cetera, et cetera. So nutrition really is important. And I had somebody last month, and a nice patient, smart, and 10 days after surgery says, "Oh yeah, I'm going to go ahead and do this, ketogenic HCG diet." I'm like, whoa, wait a minute. And he says, "Oh yeah, I get 500 calories a day." I'm like, "Well, no, stop." I said, "Absolutely the wrong answer." I said, "You do that in a year, okay? If you want, we can talk about that, but no, not when you're trying to heal up a wound." So,
yeah. So would you say that it's more of a holistic approach to medicine versus just only focusing on the actual surgical aspect?
Yeah, I mean, some guys and gals are really terrific technicians, and they can, cut and sew and make things look gorgeous, and that's terrific. And then sometimes those folks are surrounded by folks that take care of a lot of the perioperative stuff. And that's okay. That's the way they've kind of set up their practice or their service in the hospital, or if you're in an academic center, et cetera, and that's okay. We were taught, basically, we wrote our own TPN orders, which is, looking back, bananas, but we did it.
Explain what that is.
Yeah, so total parental nutrition is basically if you can't use your gut. Now, if your gut works, this is going back to general surgery, is if your gut works, then use it, because when you eat food, your little cells in the GI tract go ahead and absorb those nutritional elements, and so that always
is supporting overall wellness.
Right. If the gut works, use it, and more we're finding that if the gut's happy, the rest of the body's happy, right? Mm-hmm. And so now you're starting into probiotics, you're getting into all this sort of thing. So the gut is important for everything. So those people that really cannot use their gut, and there's a couple things that you can't, pancreatitis, et cetera, so because you don't want food there to stimulate the pancreas because it's already all fired up anyway. So some folks that for whatever reason, can't eat, or they're inhibited, or whatever the case may be. So sometimes you don't want their nutrition to fall off, so you do what's called TPN, or total parental nutrition. And what you do there is then you really have to get down to the nitty-gritty of, okay, how much fat does this patient need a day? How much do the carbohydrate need a day? How much protein? How much trace elements? How much da-da-da-da-da-da-da? And we did all of this. Now they have computer algorithms for this, but remember, we did this in the 80s, 90s, where we didn't have computers.
And that was, would you say that was really,
phones?
That was really ahead of the curve.
Yeah, and then
for dealing with those kind of things.
But a lot of people really jumped on it quickly, because it was starting to get presented, and the results were night and day if you pay attention to nutrition versus not, and especially in the plastic surgery literature, because again, we're working at wounds, and okay, well, how are we going to rehabilitate this person, and how come my wound?
Because healing is really half of the if not more.
Yeah, how come my beautiful flap that I just went ahead and did just went
exactly,
and you're like, well, huh?
And I just spent this money and I want to get an outcome.
So we really kind of delved into all that nutrition wise. So now I think there's a much more consciousness of that, and people want to get tanked up as much as we can. And frankly, getting back into the reconstructive world, the wound vac changed my life. The wound vac. So what's a wound vac? So basically, you come in and for whatever reason you have yourself a big wound, and you're staring at. Okay, so there's called the reconstructive ladder, where you're like, okay, can I put this? Do I just let it go ahead and granulate in and heal on its own? Or do I try to close it? Do I put a skin graft on top of it? Do I have to swing tissue from one area to the other? And so and do I have to take tissue out of the body and plug it in, vessel to vessel and nerve to nerve?
And those are decisions you have to make immediately, right?
That's your ladder.
Right.
Now, what has happened with the wound vac, now we used to make our own wound vacs, and what it is basically it's a closed suction system on top of wound, right? So we used to go ahead and take these plastic operative sites that we go ahead and put on patients before we operate on them. And so let's say you have a big wound on your abdomen, right? For whatever reason didn't heal up, you got this kind of big wound on your abdomen. So now we go ahead and we put two suction tubes, hook them to canisters like the ones you've seen, down the patient's nose, right? And then we would put this plastic thing over it. And so now we have a negative milieu in there, and anything that's any liquid or whatever is coming out through the tubes to the drains. Mm-hmm. And so we have found there lots of good things happen. One is you kind of get a little shrinkage from the vacuum. The amount of vessels, vascularity goes up, and that's always good for if you're going to do a secondary operation, et cetera, et cetera. So, and then some folks went ahead and put this all in something about the size of a suitcase at KCI, and now it's $1 billion with a B, dollar industry. And then, and then we used to take I forgot that part. We would take you've been to a scrub sink, right? And where we scrub our hands,
right? And
you have the sponges on the back. Well, we used to take the sponges off the back where there's the rough part where you do your nails, and there's the sponge part. And we used to put the sponge part, inside the wound so that you would protect, if there was guts there or whatever, you would protect that from the suction. And so we would lay that in there. And so we did that. And then, of course, KCI did it, and now they're $1 billion company. But what you do with that is that gives you time.
Right.
So now
it buys you time to make decisions.
It buys you time to want to make decisions, but two, to get the nutrition up. Okay, that little lady that's eating saltines, well, guess what? You can go ahead and put her on. You can get her to try to eat, whether it's even if it's Ensure, you know what I mean? You can go ahead
just to get basic nutrients,
something, or TPNs or whatever. And now you look at their nutritional profile, their prealbumin, albumin, transferrin, and like, oh, look at that. Well, now you have a shot at going ahead and healing stuff. So that basically has really changed a lot of the reconstructive of ladder. So nutrition of paramount importance. Smoking we talked about. Activity is really interesting in the postoperative course as well. I think it's really important to get people up and moving afterwards and keep the clots away, et cetera, et cetera. My dad had hip surgery, and I went to see him about, it was about 3 hours after the surgery. He was already up in his room. I get up to his room, and he's sitting in one of those, high chair, seats, Phil Jackson, chairs. And I'm like, what are you doing up here? And he's like, well, they put me here. I'm like, no. And I went over to the nurse's station, like, is he supposed to be out there? And they're like, yeah, no, we do that now. I'm like, oh, okay. Protocol. I'm like, oh, okay. And so then he goes to rehab, blah, 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 and all that kind of stuff. Yeah. And then I went over to his house to change his dressing, and it was, maybe about 4 inches. And I'm like, where's the other half of it? And he's like, no, that's it. So I run into his surgeon, his orthopedic surgeon in the doctor's lounge. And I'm like, I went and changed it. It's this big. And he's like, yeah, the instrumentation now has gotten so good that it swivels and swivels, and you're able to put it in and all that stuff. So we learned from activity a long time ago, again, back in the 80s, 90s, and we had, especially on the orthopedic service, where in bed with them, they have these machines that would go ahead and would bend the knee and bend the knee and bend the knee. And now these folks are getting up and at it, a lot faster. I mean, we used to keep at the VA in Philadelphia, again, 30-something years ago, we used to keep hernias in-house for, 5 days, and now so much more more surgeries are being in an outpatient setting. They're doing total
joints. A lot of
it's
just less invasive anyways, right? With the endoscopic.
Yes, the technology's gotten so much better, and the perioperative care has gotten so much better that you're able to get away with it. But activity, now, some activity is good. Lots of activity, not so good.
Yeah, activity to one person is different to another person.
Right.
Have to kind of define that, I guess.
So again, now especially with folks that have a surgery, you can't go home and do 100 push-ups and then try to figure out, why, you have a hematoma, right? So you really do have to, listen and get guidance as far as what activity to do. Like, for example, my tummy tucks, they're up and kind of piddling around the next 3 days, and that's a good thing, but they're still kind of a bit hunched over and looking a bit like Groucho Marx, and that's okay. But
and that is, that's a major surgery. I've actually seen that surgery.
Yeah.
I filmed it, and there's a lot of parts to that too. Part of it was sewing together the muscles, which was very interesting. And maybe you could talk a little bit about that.
So we change the anatomy, right? So we go ahead and we do the muscles, and then we physically sit them up at about 30 degrees because we take off the swath of tissue, and we physically. So laying on the table, there's no way you're going to get these ends together, right? And so what you do is physically sit them up at about 30 degrees, and so now you can put everything together. And you have to bend the bed, and you have to make sure that when they're walking around and going out to the car that they're still bent over, et cetera, et cetera. And then eventually, in 7 days, sometimes longer than that, 14, 21 days, whatever the case may be, people finally kind of straighten themselves up, depending on how much tension's across the wound, et cetera. So again, those folks, you don't want to put a lot of tension on them. Those folks should not be twisting about the waist and that sort of thing. And so again, you want to cut on tension, sew on no tension, and basically keep tension off of wounds, especially if they're on high tension to begin with on purpose. And
how important, and on our talking points here, talking about family members and just support, post-operative support from family and friends, how important is that for a successful recovery?
Yeah, I think that's really important. I mean, one is I always like it when somebody brings in somebody extra to the preoperative conference, and hopefully that person that's going to be taking care of them afterwards, because they've done the studies, and most people take away about 30% of what the doctor says, right? So
it's always good to have a second set of ears.
Because you say that? Yeah, you said that. Oh, okay, yeah. And we try to do it all, right? We try to do it visually. We try to do it orally. We try to, we give them a book. We draw pictures. We do all this stuff we can, because some people are a different type of learners. Okay, fine. And we like to pride ourselves that we really teach a lot, but sometimes, again, the message doesn't get across for whatever reason, et cetera, et cetera.
And people are nervous when they come in.
People are nervous, right? People aren't thinking of how many times I'm supposed to take this medicine.
Exactly.
So okay, it's written down. Yeah, I'll get it later. So the other thing is I think it's important to bring the family member or friend in, and now with COVID, you can do that now, since we're kind of hopefully getting out of all of that, because it was no people in the room, that was a mess. And the other thing too is please do ask questions, right? Guys, most guys and gals that I know won't be offended by a question, especially if you're a concerned family member or a patient and saying, doc, I still don't understand it. It's okay. You know what I mean? And we come in and we have a big white coat and we have all these letters after our name and all that good stuff. But I still think it's important to connect with the patient and the patient's family and try your best to go ahead and teach. And if it's in a different language, that's okay. Go ahead and bring another member, and that takes longer, but okay, I'd rather have that.
Yeah, it's really whatever's going to support the best outcome.
Right, and we have every plastic surgeon in Vegas that I know has a Spanish speaker in the office. 3 of them are native Spanish speakers. So again, we're trying to break down those barriers and kind of demystify things. But key to ask questions. And again, no such thing as a silly question, because again, I've played this game thousands of times, and this may be the first time you've ever played this game. So it's okay to ask questions, especially if you're a rookie at it. And that can be anything from nutrition to when do I give them their pills to how do we wear that garment again, or what's the strain thing. And so it's okay. And I tell them too is call. I want them to sleep, meaning that I don't want them to be worried and be up at night. I want them to call me, get an answer, and go to sleep.
Right.
So that's kind of my, philosophy.
And you have a great team, a great office team that can help with that, answering those questions as well, even if you're not particularly available yourself.
Right. So, if I'm physically not available, we have people that's been in the office with me 15 years, 17 years, 10 years. They kind of know the drill by now, one hopes. And so, and that for me, that helps me and moreover the patient a lot. So that's all important is the perioperative care, and we try to pride ourselves on that and make it the best experience that we can, because nobody likes coming to the doctor. We're the good news doctor. We can, but typically fear brings people to the doctor. Oh my God, what is it? It's a lump. What is it?
Right.
I'm feeling right. What is it? So, we're kind of on a different branch of medicine where people don't.
It's elective.
Yeah, it's elective, which is great because you have you have time. You have the luxury of time, so you can go ahead and get people's nutrition status up. You can get people to quit smoking. You can get. Oh, wait a minute. This month's no good, but next month I can get my Grandma Gertrude from Walla Walla, Washington to come and take care of me. Great, call Gertrude. Right. So a gunshot wound, you got to move right away, right? Yeah. So with aesthetic surgery, you have the luxury of time to set up your universe so that it works. And we talk about this all the time, especially with folks with windows like the cops, firemen, school teachers, especially. What military personnel? What can we do? And the staff in my office is really good at that Tetris game about trying to
it's because it's not easy to keep that all together and make it all work, right?
But it's always it's always interesting. But post-op care is always is important and always a challenge. And sometimes life happens, right? So this one gal came in. I forget the surgery. I think it was breast dog lift. Anyhow, so I said, hey, no twisting, no. She wasn't ready yet to dunk in the water, right? She can be in a shower, but not, I said no hot tub, no beach, no jacuzzi, right? Usual. And she comes in, she says, Doc, I think you're going to be a little mad at me. I'm like, well, why? Well, I was on the boat and my 9-year-old on the lake, and my 9-year-old fell off, and I dove in to save him. I'm like, that's okay.
Yeah, that's a good excuse.
We'll accept that. I said
it's a little different than my dog ate my homework.
Yeah, so I'm like, that was a good decision. So yeah, there's always that. We have patients roll in on their post-op. Their post-op checkup with like a suitcase, like, oh, where are you going? I'm going right here to the, to roll it in behind him.
Flying to London.
I'm flying out. I'm like, okay.
Yeah, I know.
And we do get a lot of international visitors and everything else. So we're used to that. But that's fine as long as like they're not rolling a suitcase.
Right. As long as
you make arrangements for that. Yeah.
As long as they're being careful.
Yes.
Can you let everybody know how they can contact you?
Sure. So we are all over the place. The cornerstone, of course, is the website, which is now relatively new. But if you find typos, please let us know. We're still working through it. That website is JJRothMD, JJRothMD.com, JJRothMD.com. And also... we have a ever widening exposure on social media, Instagram, Twitter, Facebook, LinkedIn, this podcast, obviously. And we do check our DMs. We do check the emails, and we get a lot of, in fact, this whole broadcast was about questions that we get often from patients and their family. Mm-hmm. So if you have questions, again, one of our missions is to demystify plastic surgery and medicine as well, because people are scared because nobody really likes to interact with a doctor unless that there's something going on, and it's like a big dark room, and we try to turn on the lights and it's a desk and a chair. Well, it's not scary anymore. So again, we try to take this
demystify.
And try to take the scary out of that. And you're like, oh, well, this is going to happen next, and this is going to happen next. Oh, really? Oh, okay. Oh, I get it. So yeah, and again, I would rather people spend 20 minutes with me than 20 hours on the internet, because Dr. Google often is not your friend, and so by all means.
So true.
There is some good information out there, and there's some not so hot. So I would much prefer somebody coming in and talking to me or another board-certified plastic surgeon like me, that cause at least you're going to get taken care of, and they're up to date typically, really well on the literature, and they have friends that they can bounce ideas and questions off of. So any questions or anything else like that, please don't hesitate. Give us a call, and we love answering questions.
Absolutely, and please make sure to like and subscribe to our podcast to hear future episodes. And we have a whole catalog of our past episodes available, which we invite you to check out. So thanks so much for joining us, and have an awesome day, everybody.
Have a fantastic day, and we'll see you again soon.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffre Roth. See you next time.